Welcome to our tutorials. Today we'll be discussing on non-steroid anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. Now, when you say non-steroidal anti-inflammatory drugs, what are we talking about? Simply, there are some drugs that they can help fight against inflammation. These are majorly steroids. These are what steroid does. They can bring about anti-inflammatory effects. However, there are some drugs that they are not steroid, but they can also bring about anti-inflammatory effects. They can help combat inflammation, and that's what we refer to as non-steroidal. They are not steroid, non-steroidal anti-inflammatory drugs, but they can reduce, prevent, or minimize inflammation. So that's the first point. The term non-steroidal anti-inflammatory drugs is used to distinguish those drugs that are not steroids. Distinguish them from steroids. You get non-steroidal anti-inflammatory. You use that term to distinguish them from steroids because they have similar anti-inflammatory action. So the same way steroids have anti-inflammatory action, these drugs also have anti-inflammatory action, but they are not steroids. All right. Non-steroid anti-inflammatory drugs are non-narcotic. They are non-opioids, but they actually look like aspirin. They are aspirin-like, and they can also bring about analgesic effect. We'll see that as we are moving on. Generally, for you to be among non-steroid anti-inflammatory drug, that drug must have three main effects. It must have anti-inflammatory effects, it must have analgesic effects, and it must have what we refer to as antipyretic effect. It can reduce the temperature. Do you get now? All right. Now, how does this drug actually act? This is just like, we'll talk about it more in the next slide. For them to act, one of the primary cause of inflammation is prostaglandin. Just take note of that. Prostaglandin is one of the major cause of inflammation. That's a neurotransmitter or a hormone. It's also a hormone. It's one of the common is one of the common cause of inflammation. Now, if you can, this NSAID majorly reduces the amount of prostaglandin. They prevent the formation of prostaglandin. So when prostaglandin is reduced, it's not formed, then inflammation can be dealt with. Now, how do they do this? Take note that what helps to form this prostaglandin is arachidonic acid. The enzyme that will convert arachidonic acid to prostaglandin is what we refer to as cyclooxygenase. Another enzyme that also helps to form prostaglandin is called prostaglandin synthase. So, how does NSAID fight against inflammation? They do this by inhibiting the prostaglandin synthase that's supposed to help to form prostaglandin. They also inhibit cyclooxygenase. When you see COX, COX, it means cyclooxygenase. These enzymes are inhibited so that prostaglandin will not be formed. Most of the NSAIDs that actually inhibit this cyclooxygenase, they actually do their action reversibly. Like the actions are reversible. The NSAIDs are competitive reversible inhibitors of cyclooxygenase. However, there's one example of a drug that inhibits cyclooxygenase irreversibly, and that's aspirin. So aspirin inhibits cyclooxygenase irreversibly. So just take note of that. In our next slide, let's look at a very important point now. Let's look at this first, the mechanism of action, which we've explained already. So aspirin and other NSAIDs, and NSAID that we just mentioned, they help to inhibit cyclooxygenase enzyme and prostaglandin production. So once cyclooxygenase is what helps to form that prostaglandin. So once you can reduce cyclooxygenase, you can prevent the formation of prostaglandin. There are different types of cyclooxygenase. We have cyclooxygenase 1, cyclooxygenase 2. Of importance to know, most cells or all cells, but let's use the word most cells, but later you see all in some place, but most is better. Most cells in the body actually have cyclooxygenase 1, not cyclooxygenase 2 receptor. So cyclooxygenase 1 is expressed in most cells, not all cells. let's use the word most, almost all cells in the body. It is the major receptor that cyclooxygenase 1 is majorly binding to receptors for the normal activities of prostaglandin, the normal housekeeping function. But cyclooxygenase 2 is more importantly seen in inflammation. Cyclooxygenase 2 is also more importantly seen in events involving cancers. You get, cyclooxygenase 2 is more seen too in events involving cancers. Cyclooxygenase 2 is not found in all cells. It is cyclooxygenase 1 that is found in almost all cells. Do you get? Now let's look at this brief diagram. In this brief diagram, you can see arachidonic acid here. Arachidonic acid is what is converted to this prostaglandin. There are different forms of prostaglandin, E2, I2. These are forms of prostaglandin. It is arachidonic acid that is converted by the help of cyclooxygenase. So we have cyclooxygenase 1 helping, cyclooxygenase 2, you can see. Do you get now? All right, let's quickly look at the difference between cyclooxygenase 1 and 2. How can you differentiate them? Cyclooxygenase 1 is expressed in, take note, cyclooxygenase 1 is expressed in all tissues. Do you get now? Or almost all tissues. Cyclooxygenase 2 is found in specific sites, which you must know. It's found in the renals, it's found in the brain, it's found in the endothelium, and it's found in fetus. Yes, these are the regions where cyclooxygenase 2 can work, because that's where the receptors are located. Do you get? Now, so imagine they say cyclooxygenase causing for example, they say cyclooxygenase causes platelet aggregation. Does it bind to cyclooxygenase 1? Okay. Now imagine that you are told that cyclooxygenase, which of the following cyclooxygenase will bind to its receptor to cause platelet aggregation. Do you get now? Simply put, it is cyclooxygenase 1, because cyclooxygenase 2 does not have a receptor in the platelets. We just mentioned the regions where you can see it. Do you get now? So it is majorly found in the brain, in the renal, in the kidney, that's renals, in the endothelium, and in the fetus. So it does not cause platelet aggregation because it's not found in that region. But will it cause salt and water retention? Yes, because it's found in Vienna, in the renals, in the kidneys, and it is found in the brain and kidney. So you can see these are important points you should remember. Take note, we've already mentioned it is cyclooxygenase 2 that is responsible for inflammation primarily, and it's also responsible for cancerous agents. But the normal housekeeping activities is cyclooxygenase 1 that is responsible for it. Cyclooxygenase 1 is found in almost all cells. In the stomach, it is there. In platelet, it is there. So when you hear platelet aggregation, it is majorly by cyclooxygenase 1. Do you get now? All right. Please, let's go to a slide that we actually jumped. We jumped it because it's very important. We can talk about it now. You want to now classify the drugs that you can use to inhibit cyclooxygenase. Do you get now? Now we've already established the fact that for prostaglandin to be formed, prostaglandin needs cyclooxygenase to be formed, because it is converted from arachidonic acid. Arachidonic acid is converted to what? To prostaglandin by the help of the cyclooxygenase. So what are the things that can inhibit cyclooxygenase? Remember, we have cyclooxygenase 1 and 2. I've mentioned it before, because the inhibitors, there are some that can inhibit both cyclooxygenase 1 and 2. Do you get now? So we refer to them as non-selective cyclooxygenase inhibitors. Non-selective. Then there are some that are selective for cyclooxygenase 2. They just inhibit cyclooxygenase 2. There are some that are preferential for cyclooxygenase 2. That means they inhibit cyclooxygenase 2, but they can also inhibit cyclooxygenase 1. So they are preferential for cyclooxygenase 2. Do you get now? All right. So let's talk about the non-selective cyclooxygenase inhibitor. This one, they just inhibit cyclooxygenase 1 or 2. They inhibit both of them. Do you get now? Example is aspirin. Aspirin is non-selective. These top stuffs here are the non-selective. Aspirin is non-selective. Then another non-selective, you can see ibuprofen, naproxen, You've heard of it, ibuprofen is being sold it's a painkiller. Most people, if some persons abuse it. All right. We've seen piroxicam. These ones are used in treatment of gouty arthritis. Piroxicam. Other example, indomethacin, which we'll also talk about. You can see indomethacin here. Indomethacin, we'll talk about it. It's a very good agent, you should remember. It's a non-selective. It can inhibit both cyclosporines 1 and 2. So just remember the major example: aspirin, ibuprofen, naproxen. This ibuprofen, this naproxen there. All right, this is piroxicam. This is indomethacin. You can remember indomethacin. These are common agents. Then selective for COX-2, the one that can just inhibit cyclooxygenase 2, like selective cyclooxygenase 2 inhibitor. That's why you have things like selecosib. They end with cosib majorly. Selecosib. You have something like etoricosib, something like pariocosib. Do you see the tree there? Pariocosib. This is selective for COX-2. They inhibit COX-2 only. Then preferential COX-2, they inhibit COX-2, but they can also inhibit COX-2, but they prefer to inhibit COX-2. Preferential COX-2, that's where you see what we refer to as diclofenac, which you've heard of. People take it a lot. And that one is a normal drug that people take a lot. Etodolac, they take that too, but not common. Diclofenac is very common under this category. So these are example of of NSAID, the non-selective. Take note, where you have something like aspirin, and the other example we mentioned, ibuprofen, etc. Then take note, they used to ask about COX-2 selective, which is those selecosib. They used to ask about them. Okay, then let's now move on. We are through with this slide. Let's now talk about irreversible cyclooxygenase inhibitor. That means they can inhibit both COX-1 and COX-2. And remember, aspirin is an example. Is that not true? Aspirin is an example of that. So since they can inhibit both COX-1 and COX-2, can they cause can they affect platelet aggregation? Yes, they can. So because the COX-1 is majorly responsible, it's found in platelets. Okay. Next, this is COX-2. Remember, we said COX-2 is majorly responsible for inflammation and causing cancer. COX-1 is the one that you predominantly see in the GIT. Take note, because COX-2 is not found in GIT. We did not mention COX-2 being found in GIT. Okay, these are just example of what we said before. Can now move on. This is a very important slide. Now I want to look at the features that the effect that cyclooxygenase non-selective COX inhibitor can cause. Non-selective that can inhibit both COX-1 and COX-2. What can they cause? They want to see what selective can cause that can inhibit just COX-2, selective COX-2. All right. So for analgesic effect, remember I said for you to be an example of an NSAID, you must have analgesic effect. Do you get now? So both of them have analgesic effects. Good. For antipyretic, reducing the temperature, help to treat fever, you must have that. Both of them have it. Anti-inflammatory, both of them have it. Platelet aggregation can be caused by cyclooxygenase 1. Do you get now? So non-selective inhibitors that inhibit both COX-1 and COX-2 can have an effect on platelet aggregation because they inhibit both COX-1 and COX-2. But selective for COX-2 will not have any effect on platelets. Do you get? So non-selective, they have what we refer to as antiplatelet aggregation. It don't cause platelet to aggregate. Do you get that now? They don't cause platelet to aggregate. Take note. Non-selective we have it, but COX-2 selective will not. Gastric mucosal damage. NSAIDs are one of the most common causes. After H. pylori, 30% of ulcer, bleeding ulcer is caused by 30% of ulcer is caused by NSAIDs. Will it be the NSAID that inhibit COX-1 or NSAID that inhibit COX-2? It will be the NSAID that inhibit COX-1. That's the non-selective that inhibits COX-1, because COX-1 receptor is found in the GIT. So this is positive for COX-2. They don't bring about GIT damage a lot. They don't majorly have receptor there. Retention, salt and water retention, both of them will do that because COS2 receptor is also found in the renals. Both of them will cause delay in labor, for closure of ductus arteriosus, which I will discuss about later as we are going. It is majorly COS1 that will do that. Asthma sensitive, aspirin sensitive asthma precipitation is majorly non-selective. COS2 will not do that. So just take note of this difference. All right. Now, these are some important features that they have already seen. Anti-inflammatory. They can combat against inflammation because they inhibit prostaglandin and they prevent its formation. Analgesic effect, they can reduce pain. Can help reduce pain by actually reducing some mediators of pain, such as bradykinin and 5-hydroxytryptamine, which give rise to serotonin. These are things that cause pain. They can inhibit those ones, so they can inhibit pain. Antipyretic effects, they can actually act on the hypothalamus to reset. The hypothalamus has the thermoregulatory center. They can act on that thermoregulatory center and reset to reduce temperature. Okay, next slide. Therapeutic effect, the anti-inflammatory. Just take note of this. Acetaminophen, which is referred to as paracetamol, is not an NSAID. Though some few persons may put it as an NSAID because it does not fit in. It has antipyretic effect. Yes, you can use paracetamol to reduce the temperature. It has analgesic effect. You can use to reduce pain, but it is devoid of anti-inflammatory activity. You call them NSAID, non-steroidal anti-inflammatory drugs. How will you be an NSAID without having an anti-inflammatory activity? So acetaminophen is not an NSAID, but some people classify it as NSAID. I don't know why. Anyway, so that's that. So the therapeutic use, what do you use NSAIDs for? Use NSAID for anti-inflammatory, use NSAID for analgesic, use NSAID for antipyretic. Okay, let's continue. In the fetal circulation, you need NSAID. What do you use NSAID for in fetal circulation? There's what we refer to as ductus arteriosus. The ductus arteriosus simply is what helps to prevent in fetus, the lung is not active, the lung is not working, so blood is not actually going to the lung. Only less than 10% even goes to the lung. So blood does not go to the lung in fetus. The baby does not need the lungs to get its blood oxygenated. Do you get now? Now any blood that's supposed to be flowing to the lung is being shunted away from the lung. It's moved away from, pulmonary artery is supposed to take blood to the lung. Yes, so that pulmonary artery is supposed to take blood to the lung. There's something that is shunting blood away from it, pulmonary vessel, that will not take blood to the lung because the lung is not working, it's not active, it's undergoing development. Do you get now? That's what we refer to as the ductus arteriosus. It helps for that shunting. Now, after you've given birth to a child, this ductus arteriosus is supposed to close. Do you get now? So that the lung, because the lungs become active immediately after birth. So for some individual, it may not close, and that's what we refer to as patent ductus arteriosus. You can use NSAIDs to help treat that condition, and the NSAID you can use is indomethacin. Remember, I said you should remember indomethacin. This is one of its important use. Indomethacin and ibuprofen. Remember, these are example of a non-selective, both COS1 and COS2. All right. Cardioprotective effect. Aspirin is used to reduce serious vascular events in patients. How does it do this? Aspirin actually prevents, remember, we said aspirin can inhibit both COS1 and COS2, and COS1 majorly have its effect on platelets. The effect on platelets is that they can prevent platelet aggregation, antiplatelet aggregation. Once platelets does not aggregate, clotting will not be formed. Generally, when there's clot formation, it helps to prevent blood loss. But in some individuals, they tend to be just excessive clot formation even when there is no injury, and as such it can be detrimental. So you can use aspirin to prevent that from happening. Do you get now? Aspirin can suppress thrombosin A2 formation, and thrombosin A2 is important for this clotting of blood to occur. As simple as that. Other indications of use: when somebody has fever, you can use it. When somebody is having night pain, you can use it. Moderate pain, you can use it. Rheumatoid arthritis, osteoarthritis, inflammatory arteriopathies, acute gouts, dysmenorrhea, metastatic bone pain, headache, migraine, post-operative pain, injury, patent doctors arteriosus. These are all conditions you can use them for. Other conditions you can use them for, we'll continue. There's what we refer to as systemic mastocytosis. You remember mast cells? Yes, mast cells contain prostaglandin. We've already mentioned it at the introductory aspect of this lecture. Mast cells contain prostaglandin, and the prostaglandin that is contained in mast cells and other, because mast cells, we said it contains granules that has many content, not just prostaglandin, histamine, and all of those content that can cause inflammation. In some individuals, you say systemic mastocytosis, there's excessive release of these mast cells. They rupture and release their contents. How will you help this person? Because the person will be coming up with symptoms of flushing, vasodilation, hypotension. To help this individual, you can use what we refer to as aspirin or ketoprofen. These are NSAIDs. If you give this person antihistamine, it will not work. Systemic mastocytosis is resistant to antihistamine, so you use them to treat. You use NSAIDs to treat. Okay, niacin intolerance. Niacin is vitamin B3. Yes, some persons they don't tolerate niacin. So for this type of individual, when they take niacin, they have flushing. So you can use aspirin to solve the issue for them. Bartter syndrome. Bartter syndrome is a syndrome that affects a channel in the kidney that helps for reabsorption of water. You get now? It affects the channel. Refer to as, just know this channel is important. Sodium potassium chloride co-transporter. It affects this channel in the kidney and causes derangement in electrolyte imbalance, causes derangement in water absorption and secretion. Do you get now? You can treat this using indomethacin, and you can also use what we refer to as spironolactone, which is a potassium sparing diuretics. You can also use that to treat. All right. In the GIT, we want to talk about the adverse effect in the GIT and in other aspects of the body. In the GIT, it can cause nausea, vomiting, it can cause bleeding. Yes, it's one of the causes of ulcer. So it can cause ulcer, gastric erosion or ulcer. So when there's ulcer, there can be bleeding ulcer, it can cause it. The person will not want to eat. The person eats and vomits, can have diarrhea, pain. These are all examples of adverse effects, gastrointestinal adverse effects. Then in the platelet, remember we said in platelets they prevent the platelet from aggregating. I know aggregation of platelet helps blood to clot, so that when somebody has injury, it will clot. There will not be excess blood loss. You get now? Now imagine it prevents platelet from aggregating, and therefore the person can have bruising. When there's bruising, the person will just start to bring out blood because the platelet is not clotting anymore. Do you get now? There's no clot formation because the platelet is not aggregating. Do you get? So it inhibits platelet activation and aggregation. It can potentiate bleeding. There's increased bleeding, there's increased hemorrhage. All of that is for that. Then for renals, it causes salt and water retention. That's what they do. NSAID causes salt and water retention. Both the one that had on cause 1 or cause normally cause 1 and cause 2. Yes, anyone that they can cause salt and water retention, any of them. So when you cause salt and water retention, excessive water and salt retention, that can cause edema. Is that not true? And that can worsen cardiovascular diseases. Also, one of the way antihypertensive drug act is that they help to reduce some diuretics are antihypertensive. Yes, they help to remove water from the body. So this one is causing salt and water retention. It will not allow those antihypertensives to work. So it decreases the effectiveness of some antihypertensive. It decreases the effectiveness of some diuretics. So that then for cardiovascular, it can cause closure of ductus arteriosus. Remember, it can cause closure of ductus arteriosus too early. It can cause myocardial infarction, stroke, and thrombosis. Take note: low dose aspirin does not cause myocardial infarction, stroke, and thrombosis. All right. Then this is in CNS, vertigo, it's as if the earth is turning around you, dizziness, headache. In the uterus, take note: NSAID can cause prolongation of gestation. Why? Because prostaglandin you are preventing is what causes labor. It is one of the major things that causes labor, contraction of the uterus, so that the baby will come out. Now you are inhibiting prostaglandin, preventing its formation, so you can prolong labor. Inhibition of labor. All right. These are other adverse effects. People are hypersensitive to NSAIDs, and they can actually come up with this. So that's that for NSAID. So let's quickly look at an example. We'll look at an example of NSAID in the next class, and that's aspirin.